In this section, we're going to just talk about the specific principles of exercise and how we are going to take those into consideration when designing our programming for our patients and our clients. Knowing that it's really those ideas, theories, fundamental truths. A lot of this is ground in research that dates back to the 80s and 90s and is still being proven and useful today. Sorry about that. Let's start with individuality. This is important for us just to remember when we're training our patients and clients, is that really optimal benefits will occur when programs meet the needs and capabilities of the participant. So example would be that Dr. K loves to do yoga, and if I had my husband do yoga, it would not be very beneficial. He wouldn't like it. He's very stiff. It's hard for him to do. But if you flip-flop, he loves basketball, and the opposite might be said of Dr. K. And so maybe we have a case of individuality. And so thinking through that with programming, I want you guys to think about if you were a technician or if you were ever injured, did you want to be treated as a shoulder patient, or did you want to be treated as who you were and what was important to you and where you were at in that specific time of your rehab or your life? Trainability, this is really that each person responds differently to the same stimulus. And this we can see, this will change as we age. Can change with gender. It can change with stages of development. A lot of research has gone into the optimal time of trainability, and a lot of that is in our youth. And we develop a lot in those really kind of adolescent years. And so just understanding that. It's also understanding where do we start at in regards to our level of fitness and our level of skill. If we think about someone is coming to us and they've been at a certain skill for a very long time, so you have an electrician and he's used to that, his memory of that is a lot different than would be if you're training someone who's never performed the skill that maybe wants to start doing that again. It's pretty cool. There's new studies coming out now that show fascia carries memory in and of itself, independent of the brain and the connections in the brain. And so sometimes we used to hear empirically that, oh, it's muscle memory, but maybe there is something to that, and there's some proprioceptors and receptors in the fascia that maybe do have some of that. So we'll just take that into consideration. Also, just want to take into consideration that motor planning is a key part of rehab, and so it might take a little bit more if we're working with someone that isn't a mover. This comes to mind for me in a lot of patients that I've seen maybe in their 60s or later, in the later decades of life, that maybe just didn't grow up with that much exercise. And it's just been wonderful to actually see the transition. And once you show them through that kinesthetic learning what it feels like and how they can do it, you can get them into some programs after you're done with your rehab that are really remarkable. Specificity, we've heard this a lot, especially with rehab and making sure that we're doing specificity of training. And the training stimulus must be specific to the desired outcome and or task to perform. A really cool example is a study that was performed at the University of North Carolina. The researchers had 7 male distance runners increase their training intensity. They replaced 3 days a week of training with interval style training, and they trained at 90 to 95% of their max heart rate. All the other training days, the runners followed their normal training program. What was pretty cool about this is that after the 8 weeks, the runners demonstrated a really big improvement in their performance, their ability to delay fatigue while running at higher intensities. And they're able to do this because their body learns how to move more efficiently and remove lactic acid. And that really is a main factor for fatigue for us. However, really, they saw that these same runners tested at lower intensities their training didn't improve. And the adaptation to the interval style training was specific to the interval trial training, and it didn't carry over into their prolonged running that they needed to do. So this doesn't talk about type of movement, it talks about intensity of movement as well. So taking that into consideration when we're rehabbing our clients and patients. So that overload principle, this is one of those that I think is it's one of those delicate balances. And so where do you start when you have an initial injury? And we don't want to overload it too much, because if there's injury at maybe that musculotendinous junction or a labral structure, we don't want to overload that. But we also know that if we don't reach overload, then we're never really making a change, and we're not going to show greater compensation for that. So just remember that for the adaptation to occur, the volume of exercise must overload the body in some way, in line with the capacity of the individual. So I like this graph because it really does show you that there is a baseline fitness, and that our training overload, that we will come down into this area where we'll start to see that there's we start to see some deformation into that musculature. But then our body is so smart, it will try to build up that musculature so that the next time that same stimulus comes, that now we're compensated for that, and we're able to better handle that. Of course, we reach a ceiling effect, which we'll get